Morning, guys. I'm going to do a review on our discussion from this week involving cervical radiculopathy. Hopefully you guys found the papers by Schmid and also Gifford as interesting and hopefully helpful as I did, and it sounds like you did. I think a couple of take-home points from this is that people with cervical radiculopathy present on a spectrum. Schmidt's concepts of gain versus loss of function, I think, is really helpful here, where some patients come in with no findings on their neurological exam, no loss of strength, sensation, reflexes, but still present with findings such as pain going all the way down the arm, positive upper limb tension tests, reports of tingling, those kinds of things that would suggest that the cervical nerve root is involved. I think it also helps us to understand why patients will present with a wide variety of signs and symptoms spreading outside of that nerve roots field. Her research is really more in carpal tunnel syndrome, but I think we can extrapolate that to the cervical radiculopathy, where even though the nerve becomes injured in one area, because of the way that the nervous system works, peripheral inflammation contributing to central sensitization, we'll start to see a widespread symptoms in some patients. Some people are a little more textbook, but I'd say the majority, it doesn't seem to fit one nerve root pattern that we tend to see. So that can be quite confusing. I can remember being a younger clinician trying to figure out, all right, which exact nerve root is this? Or maybe treating the areas of peripheral sensitization, like, I don't know, somewhere down in the shoulder or the wrist, and being kind of confused by it. But if we kind of follow this and trace it back to, okay, there's probably one area where the nerve is injured, the other areas are involved through peripheral and central sensitization, and also creating what appears to be some separate injuries. It's probably all related to the same thing. And I think we've talked about, generally starting with treating the area proximal first, the more central area, and seeing how the other peripheral parts kind of shake out. Then you can always go back and treat the more peripheral areas. Now, that being said, a lot of patients with cervical radiculopathy do respond well to, in particular, manipulation of the thoracic spine, so don't forget about that. For all your patients with neck pain, the thoracic spine seems to be a key area, at least based on the research. In terms of management strategies, once we kind of make the diagnosis, management strategy, it's really going to be tailored to that patient, based on how they respond. Some patients respond better with sort of traction, opening techniques, others with more neural gliding or sliding types of techniques. Like I said, thoracic spine manipulation seems to be helpful for a lot of people. Cervical mobilization, I don't typically manipulate folks in the cervical spine with cervical radic. That hasn't really been studied. It just seems to be maybe a little too irritable of an area to work on manipulation if they have a cervical radiculopathy. So I think the bottom line is kind of tailor the treatment to your patient. There's no one protocol that works best for all of them. Kind of think about, what the pathophysiology is going on, what do they respond to in terms of an exam, and we'll certainly practice some of those things during our weekend lab to kind of get some more familiar with some of the hands-on parts of it. So hopefully this was a helpful week for you. Really enjoyed your guys' discussions and really diving deep into these articles and thinking how they're going to apply to your practice. So keep up the good work. This week we're going to be talking about headache and TMJ, or temporomandibular joint disorders, and how those two kind of fit together.